Welcome to XY Files podcast. I'm Vladimir Kotlov, MD, the founder of Vidma, with a medical background in urology and deep expertise in male hormone optimization and fertility. This is episode 7 of 18 in our low testosterone series. Last time we covered medications, substances, and lifestyle factors that quietly kill your testosterone. Today, we're getting into what are the main low testosterone symptoms. This matters because men usually get this wrong in one of two directions. They either dismiss real symptoms as just aging, or they decide every bad week, every flat workout, every sleepy afternoon must be low testosterone. Neither approach helps. What helps is pattern recognition, then proper testing, then matching the treatment to the biology. Remember when we talked about medications, substances, and lifestyle factors that can quietly suppress testosterone? This is where that conversation becomes practical. Suppression does not walk into your life wearing a label. It shows up as changes in sex drive, erections, energy, body composition, mood, and performance. The tricky part is that some of those symptoms are very specific, and some are shared with half of modern adult life. One principle before anything else. Male hypogonadism is a clinical syndrome. It is not just a lab result. A low number by itself is not a diagnosis. Symptoms by themselves are not enough either. You need both persistent symptoms and biochemical evidence on proper morning testing. And when you test, you do not just check testosterone and call it a day. You need total testosterone, free testosterone, LH, and FSH together. Because without LH and FSH, you cannot tell whether the problem is in the testes or in the signaling from the brain. The most specific symptoms, by far, are sexual. Reduced libido, erectile dysfunction, loss of spontaneous or morning erections. That trio carries the most weight clinically. A lot more than a vague complaint like, I'm tired all the time, which may be true, but tells me almost nothing by itself. Libido is sexual desire. Erectile dysfunction is difficulty getting or keeping an erection firm enough for sex. Morning erections are those spontaneous erections during sleep or when you wake up. They matter because they are less distorted by stress, relationship tension, or performance anxiety. Men often don't volunteer sexual details right away. They'll tell me about energy, focus, weight gain, maybe sleep. Then I ask one simple question about morning erections, and suddenly the whole picture sharpens. I had a patient not long ago, early 40s, very typical story. He came in talking about fatigue and burnout. He thought the problem was work. Maybe it was partly work. Then we got into the details. Libido had clearly dropped. Erections were less reliable. Morning erections had become rare. He hadn't connected those dots, or maybe he had and just didn't enjoy saying them out loud. That happens all the time. Men will normalize sexual decline for years if nobody asks directly. A major paper in the New England Journal of Medicine looked at this and found that this sexual cluster gave the strongest diagnostic signal for late-onset hypogonadism. That fits what I see in clinic every week. If a man tells me he is a little tired, I think broadly. If he tells me his sex drive is down, erections are weaker, and morning erections have faded, my suspicion for testosterone deficiency goes up fast. Loss of morning erections is especially useful. Not magical, not perfect, but useful. Mood can affect desire. Relationship stress can affect performance. Morning erections are a bit more honest. The body is not trying to impress anybody at 5:45 in the morning. There are other sexual changes that can matter too. Less sexual thinking, less interest in masturbation, less frequent sex than is normal for that man. Delayed ejaculation. Those can belong to the picture, but they are less specific. Stress, depression, sleep loss, medication effects, and relationship issues can all create the same pattern. In other words, those symptoms count more when they travel with the sexual triad, not when they show up alone. Then there are the symptoms that bring a lot of men in first. Fatigue, low mood, irritability, less motivation, brain fog, poor concentration, memory complaints. These are real. I'm not minimizing them, but they are weak evidence for low testosterone by themselves because they overlap with sleep disorders, depression, thyroid disease, obesity, anemia, chronic pain, overwork, under-recovery, and plain old bad habits. This is the mistake I see most often. A guy has low energy. Maybe he gained 20 pounds. Maybe work is rough, sleep is bad. He's drinking more than he admits. And somebody told him, sounds like low T. Maybe, maybe not. When you zoom out, a lot of modern men are sleep deprived, stressed, under-muscled, overfed, and metabolically unhealthy. Low testosterone may be part of that. It may also be the downstream effect, not the original cause. Physical symptoms often show up as reduced function before they show up as some dramatic mirror moment. Men tell me they do fewer hard workouts. Recovery is worse. Strength slips. They avoid vigorous activity because they just do not feel as capable. Their waist keeps growing even though they think they are eating about the same. They feel stiffer, slower, less resilient. Sometimes even longer walks feel different. Not terrible, just off. That off feeling is easy to ignore because it develops gradually. Think about a car that drifts out of alignment 1 degree at a time. You adapt without realizing it. Then one day you drive a properly aligned car and remember what normal felt like. Testosterone deficiency often behaves like that. It creeps. Men adapt to the new baseline. Then they call it aging. When I was a resident, I used to think men would notice low testosterone quickly because the symptoms seem obvious on paper. I was wrong. The gradual onset is exactly why it gets missed. Nobody wakes up one morning and says, my lean mass appears to be down 7% and my androgen axis may be suppressed. He says, I'm not recovering like I used to, or I just don't feel like myself. Body composition changes deserve more respect than they usually get. Lower testosterone is closely linked with less lean mass and more visceral fat. In real life, men experience that as smaller muscles, less strength, slower recovery, and more abdominal fat. They blame the gym program, or their age, or the fact that their kids ruined their sleep 3 years ago and somehow it never quite came back. Sometimes all of that is partly true. But if those changes are happening alongside reduced libido and fewer morning erections, the pattern becomes much more meaningful. This is also where functional hypogonadism enters the conversation. It is probably the most common thing we see in the real world. The axis is intact, but it is being suppressed by reversible conditions like obesity, metabolic syndrome, type 2 diabetes, and certain medications. The testes can still respond. The signal is just muted. In that situation, if LH is below 8 milli-international units per milliliter, enclomiphene is often a very good first-line treatment because it works upstream by increasing LH and helping the testes produce testosterone naturally. Lifestyle still matters, a lot, but I try to be honest about it. Weight loss can improve testosterone, but the average increase is often modest, around 1 to 2 nanomoles per liter. And most men regain a large share of lost weight within a few years. That is not me being cynical. That is me respecting how hard long-term behavior change actually is. The best approach for functional hypogonadism is usually both. Improve the underlying drivers and support the axis at the same time. Psychological symptoms sit in a strange middle ground. Low mood, low motivation, irritability, poor concentration, poor sleep. These can absolutely show up with testosterone deficiency. A meta-analysis in JAMA Psychiatry found that testosterone treatment improved depressive symptoms in some men, but mood symptoms alone are still too nonspecific to define hypogonadism. If all you have is low mood and brain fog, I'm thinking broadly. If low mood and brain fog come bundled with low libido, worse erections, and body composition changes, now we're building a clearer case. Age changes how symptoms appear too, although we're going to spend a full episode on that next time. If hypogonadism starts before puberty, the picture is very different. Delayed puberty, poor virilization, different body proportions. Adult onset is much sneakier. It usually looks like gradual decline in sexual function, energy, recovery, and body composition. Same hormone problem, very different clinical picture depending on timing. You may have seen questionnaires online like ADAM, AMS, or QADAM. These can be helpful as symptom checklists. They help men remember what changed. They give some structure to the conversation. They can help us track progress over time. That part is useful. What they cannot do is diagnose hypogonadism. They produce too many false positives. Depression lights them up. Bad sleep lights them up. thyroid problems, obesity, medication effects, aging, stress, all of it can raise the score. A positive questionnaire means there may be symptoms worth evaluating. It does not mean, congratulations, you have low testosterone. The internet is very generous with that diagnosis. There are also red flags that suggest a specific cause and deserve real attention. Headache and visual changes can point toward a pituitary problem. A history of undescended testicles, micropenis, or absent sense of smell can suggest congenital causes. Gynecomastia can point toward certain genetic or hormonal issues. In other words, symptoms are not just about how low testosterone feels. Sometimes they are clues about where the problem originates. Comorbidities complicate the picture further. Diabetes is a good example. Erectile dysfunction in men with type 2 diabetes is common and usually multifactorial. Blood vessels matter, nerves matter, obesity matters, hormones may matter too. I've seen plenty of men told their ED was just vascular, when in reality their sexual symptoms were coming from several directions at once. If a man with diabetes has ED, lower libido, fewer morning erections, fatigue, and increasing waist size, I do not assume one explanation. I test. Depression can do something similar. Low mood reduces desire and motivation. Testosterone deficiency can worsen mood and vitality. Then each condition makes the other harder to see clearly. That does not mean every depressed man has low testosterone. It means you should not rule it out casually when the rest of the symptom pattern fits. At what point do symptoms become enough to justify testing? If you have persistent reduced libido, erectile dysfunction, and loss of morning erections, especially with fatigue and increasing waist size, that is enough to move to labs. Men over 30 get told this happens far too often. Some change with age is normal. Persistent sexual decline is not something to shrug at for 2 years and then call maturity. And the testing has to be done correctly. Morning draw from 7 a.m. to 11 a.m. Total testosterone and free testosterone. We prioritize free testosterone because it helps catch men whose total level looks passable but whose biologically available testosterone is low. We use direct free testosterone measurement by equilibrium dialysis with LCMS/MS, not a calculated estimate. Most routine labs still lean heavily on immunoassays. They are convenient. Convenient is not always the same as precise. At Vidma, our men's health panel includes total testosterone by LCMS/MS, free testosterone by equilibrium dialysis with LCMS/MS, LH, FSH, estradiol, CBC, comprehensive metabolic panel, vitamin D, PSA for men 40 and up, and insulin when BMI is above 25. When indicated, we also add a lipid panel, prolactin, or TSH. We do not order SHBG separately because we measure free testosterone directly rather than calculating it. The thresholds we use are straightforward. If symptoms persist and total testosterone is below 350 nanograms per deciliter, or free testosterone is below 100 picograms per milliliter, that supports the diagnosis. It's around 350 nanograms per deciliter, to be exact. And again, LH and FSH have to be there. High LH with low testosterone points to primary hypogonadism, meaning the testes are failing. Low or normal LH with low testosterone points to secondary hypogonadism, meaning the signaling is the issue. That distinction changes treatment. If LH is low or normal, especially below 8, and the pattern fits secondary or functional hypogonadism, enclomiphene is usually the first move because it preserves spermatogenesis and works with the body's own regulatory system. If erection or urinary symptoms are also part of the picture, the enclomiphene plus tadalafil combination tablet can make sense. If LH is high and testosterone is low, that is, primary hypogonadism, and testosterone replacement is the educational standard discussion there, not because it is trendy, but because the testes cannot respond properly. It also matters that TRT suppresses gonadotropins and fertility, which is exactly why classification is not optional. A lot of guys hear all this and ask, okay, but what about me specifically? The first common mistake is assuming fatigue alone proves low testosterone. It does not. Fatigue is common in low testosterone, but it is also common in parenthood, sleep apnea, overtraining, depression, shift work, obesity, anemia, and terrible sleep hygiene. Sexual symptoms carry far more diagnostic weight. The second mistake is dismissing morning erections as irrelevant. They matter. They are one of the clearest clues you can give your provider, precisely because they are less shaped by performance anxiety or relationship stress. Men will tell me, I can still perform sometimes, so I guess hormones are fine. Maybe. But if morning erections have faded and libido is clearly down, that deserves attention. Third, one decent total testosterone result does not settle the whole case. I see men with symptoms and a total level that looks normal, but free testosterone is low when we measure it properly. I also see men tested at the wrong time of day, or on a bad assay, or without LH and FSH, which leaves us with half a map and a lot of false confidence. Fourth, questionnaires are not a diagnosis. Useful? Yes. Definitive? No. If an online quiz says you have low testosterone and your only symptoms are being tired and annoyed at meetings, I would keep my wallet in my pocket for a minute. And fifth, ED in men with diabetes, obesity, or metabolic syndrome is not only blood flow. It may be partly vascular, sure, but hormones may be part of the same picture. This is why good workups matter. Real medicine is less tidy than internet explanations. If you want a practical way to think about this, start with 4 steps. First, pay attention to changes from your own baseline, not your friend's baseline, not some 22-year-old fitness influencer's baseline, your baseline. Has libido fallen? Are erections less reliable? Have morning erections become rare? Is recovery worse? Is your waist growing while your motivation and performance are sliding? Second, if the symptoms persist, get tested correctly. Morning labs, total testosterone, free testosterone, LH, and FSH at the same time, not just one number on a phone screenshot. If you already have labs from another service, including large wellness panels, have them reviewed by someone who actually knows how to interpret male hormone patterns. Third, make sure the treatment matches the mechanism. Low or normal LH with low testosterone is a different problem from high LH with low testosterone. One suggests the signal is suppressed. The other suggests the testes are failing. If you treat those as the same condition, you make bad decisions fast. Fourth, do not separate hormones from the rest of health. Sleep, weight, alcohol, diabetes, medications, and training all affect the picture. Functional hypogonadism is common because modern life is very good at suppressing healthy endocrine function. Fixing the environment matters, even when medication is appropriate. This series is designed to build one layer at a time. Last episode was about the quiet things that suppress testosterone. Today was about how that suppression tends to show up in real life, especially the sexual symptoms that deserve the most weight. Next time, we'll get into how low testosterone symptoms show up differently at every age. Make sure you're subscribed so you don't miss it. If you've been feeling low energy or brain fog, poor sleep, low mood or motivation, weaker workouts or recovery, reduced libido or sexual performance, or unwanted body composition changes, and that sounds like you, upload your labs to Vidma for free or order labs through our special offer at vidma.com.